Alterations in cognition and sensation, central and peripheral nervous system disorders. Increased intracranial pressure. The acute central nervous system and peripheral nervous system orders are potentially life-threatening, but chronic issues mainly affect the person's quality of life. So when we're talking about increased ICP, we have dilation or constriction of cerebral blood vessels in response to changes in our blood pressure, our blood oxygen levels, and our blood pH. These all work to maintain a constant and consistent tissue perfusion. Causes of increased intracranial pressure can include brain tumors, swelling or bleeding from head trauma, infectious and inflammatory disorders of the brain, such as meningitis and encephalitis. Consequences: we have impaired cellular activity or temporary or permanent neurological dysfunction, up to and including death. So I want you to think about this when we're talking about increased intracranial pressure. We only have a certain amount of space within the skull. It is not going to expand and contract like, let's say, our belly can. So as the brain begins to swell, or we have bleeding going on within the brain, or there is a tumor growing in the brain, it can actually begin to put pressure on the brain tissue itself. And if the pressure is significant enough, then it decreases the perfusion or the blood flow in the brain. This is going to start causing some significant issues. And it can cause permanent danger or damage if there is no relief from this pressure. So consequences. I'm sorry, I already talked about that. The assessment findings. Early on, a change in intracranial pressure, the early symptom that we are going to see is going to be a change in the level of consciousness. That is one of the first things that we're going to see. So, they may have been alert and oriented, and now they're beginning to become very drowsy or very agitated or very restless. They can become stuporous, semi-comatose, comatose, confusion, periodic disorientation. With changes of the intracranial pressure, we may also see pupillary changes. This can or will definitely indicate some type of neurological issue going on. We may see altered motor function, so we begin to see symptoms that we might see with a CVA or a stroke. That would include hemiparesis or hemiplegia. We may see the abnormal posturing. We may have a loss of temperature control, an increase in the systolic blood pressure with a widening pulse pressure, bradycardia, cardiac irregularities, and respiratory pattern changes. Headache is very common and it's more severe in the morning. But if that headache increases, then we may have an increasing intracranial pressure. We may see the Cushing's triad, where the pulse rate increases initially, but then it decreases. And we have a systolic blood pressure that goes up, and we have a widening pulse pressure and an irregular respiratory rate. We may see Cheyne-Stokes respirations or vomiting, papilledema, or that decorticate or decerebrate posturing. We're going to do skull radiography, the CT scan, the MRI, maybe a lumbar puncture, or cerebral angiography. The goal of ICP treatment is to decrease the intracranial pressure because that will help improve and increase the brain perfusion. So we have to maintain our blood pressure at the appropriate ranges. We have to prevent hypoxia, and we have to ensure cerebral perfusion. So once again, we need to decrease intracranial pressure to improve or increase brain perfusion. We can do this by elevating the head of the bed, administering isotonic normal saline or lactated ringers. We may also administer hypertonic saline solutions, but do not give hypotonic solutions. The hypotonic, if you recall, is going to put fluid in the tissues, and that's what we need to avoid. We may give osmotic diuretics. This would be very indicated for cerebral edema, and this drug is commonly called mannitol. We need to give supplemental oxygen to keep the SaO2 at 95% or higher. Keep the head in midline position at least 30 degrees of elevation. Avoid hypothermia. Being too cold actually increases intracranial pressure. Seizures increase intracranial pressure, so we need to control seizures. And if we have increasing intracranial pressure, this could put pressure on an area that would cause a seizure. So we would give a drug such as diazepam to help control the seizures. If a client is agitated, we need to sedate them with maybe midazolam. Uh, Again, that agitation and hyperactivity can contribute to an elevation of the intracranial pressure. We may also put in an indwelling catheter, a nasogastric tube, stool softeners, administer histamine antagonists, and famotidine. Which of the following nursing interventions will help prevent further increase in intracranial pressure? That's elevation of the head of the bed. We're going to look at some neuromuscular disorders, and the first one we'll look at is multiple sclerosis. This is a demyelinating disease that causes permanent degeneration and destruction of the myelin sheath. This will interrupt the nerve impulse transmission, and it most frequently will occur in the young to middle aged. This is considered to be an autoimmune disease. Many clients are going to experience a gradual and continual worsening of their symptoms while they go through periods of remission. But with each exacerbation, the symptoms are going to become more severe and they're going to last longer. These clients may experience blurred vision, diplopia, the double vision, nystagmus, weakness, clumsiness, numbness and tingling of an arm or a leg, an intentional tremor, and slurred, hesitant speech, and mood swings. May also experience motor incoordination, bowel and bladder incontinence, loss of memory with difficulty concentrating, and impaired judgment. And as the disease progresses and their mobility becomes more and more decreased, they may develop complications such as pressure injuries, cachexia, deformities, and contractures. Pneumonia from decreased mobility is usually going to be the cause of death. We're going to diagnose this with lumbar punctures and analysis of the cerebrospinal fluid and electrophoresis of the cerebrospinal fluid. There is no cure for multiple sclerosis. The treatment goal is to keep the client functional as long as possible through the use of supportive care and medications. So some of the disease-modifying drugs that we may give for multiple sclerosis would be our immunomodulators. Basically, it's going to alter the immune response by enhancing or restoring the immune system, creating a toxic effect on a tumor or modifying a tumor's biology if we're treating for a tumor. One of the immunomodulators we may give would be our interferons, and there's several of those. Excuse me. So it is effective in treating this autoimmune disorder. The biggest issue with interferon is every client that receives it is going to have some degree of fatigue. And fatigue will be the limiting factor on dosage. These clients may also experience flu-like symptoms. We can also give some immunosuppressants, and basically it's going to suppress the T lymphocytes. There's a variety of immunosuppressants, some of which are going to be steroids, but there are others. We're going to potentially help reduce exacerbation of the multiple sclerosis and or calm any inflammation that may be going on. We should always, with immunosuppressants, encourage our clients to be vaccinated, but at the same time, we would not allow our clients to have the live vaccines because they could come down with the disease that we're vaccinating them for, and it could be very severe. So a variety of medications that would be in that category. Glatiramer acetate is another drug that would be used to treat multiple sclerosis. Once again, we need to watch for the adverse effects such as hepatotoxicity. They may have flu-like symptoms, etc. So when we're taking care of someone with multiple sclerosis, we need to help these clients conserve energy because fatigue can actually exacerbate their symptoms. So we teach the client to use proper body mechanics, such as holding things close to them to lift or carry, push instead of pull. Make sure they're getting appropriate rest breaks every hour. And plan activities to avoid extra movement. For example, let's say they're going to get ready to eat and they are preparing their plate. Make sure that they have everything right there in front of them, that they have their utensils, that they're not having to expend extra energy going back and forth to complete one task. So thinking things ahead. And things that are going to be used most often, keep those at arm level. In other words, we don't want them reaching up. We don't want them reaching down because we're trying to avoid any extra movement. These clients, we need to elevate the head of their bed. If they're having too many secretions, we could suction those. Make sure that we demonstrate patience and empathy to help the client deal with his or her changes in appearance, function, and lifestyle. This is an awful disease. So we need to monitor for stress symptoms such as dyspnea, tachycardia, and increased fatigue to help prevent exacerbations. The next disease process is myasthenia gravis. This is a neuromuscular disorder that's characterized by severe weakness of one or more groups of skeletal muscles. What's happening is antibodies are binding to and degrading acetylcholine receptors on the surface of those skeletal muscles. This will occur in women more frequently. These clients will have muscle weakness. They may have ptosis of the eyelids, in other words, drooping eyelids, difficulty chewing and swallowing, diplopia, the double vision, voice weakness, a mask-like facial expression, weakness of the extremities, and respiratory system. Diagnosis confirmation will be made by IV administration of edrophonium. This medication, when administered, is going to relieve muscular weakness in just a few seconds. And unfortunately, that restored muscle strength will dissipate after a few minutes. We can also do an acetylcholine receptor antibody titer, chest x-ray that might show an enlargement of the thymus, and electromyography, which would measure the electrical potential of muscles. We can give anticholinesterase medications, pridostigmine bromide, prednisone, immunosuppressants. We may do plasmapheresis, or surgically we could remove the thymus gland. So these clients with repetitive motions, they have extreme fatigue of that group of muscles. For example, maybe they are brushing their hair and they just cannot complete that task because the muscles, that group of muscles required to do the task, become so fatigued after a few movements that they're unable to brush the entire head of hair. Parkinson's disease is caused by a deficiency of neurotransmitter dopamine. Causes are unknown, but can be because of exposure to environmental toxins, such as insecticides, herbicides, or self-administration of illegal synthetic form of heroin known as MPTP. There are others potential causes such as sequela of head injuries and encephalitis. Phenothiazines are a category of antipsychotic drugs that can actually produce Parkinson symptoms. These pseudo symptoms are, if you didn't know better, you would think the client had Parkinson's, but it's only caused by the medication. So these clients have some very classic symptoms. They're very stiff and rigid. They have that tremor of the hands, especially, and we call that pill rolling. They have bradykинesias or slow movements. They can have drooling, rhythmic head nodding. Their blinking reflex is decreased. They have a mask-like expression and a stooped posture. They have hypophonia. In other words, they do not have a very large or loud volume of speech. Their gait is very shuffling. They just kind of scoot their feet along. They can't really pick their feet up very well, and they have difficulty redirecting that forward motion. We can diagnose it based on typical symptoms and neurological examinations, but there's not really a specific test for this disease process. Medically, there are drug therapies available, and the goal is to produce or prolong the client's independence. But it's very important that these clients maintain their medication schedule. They can't take their medication at 9 o'clock one day and take it at 1 o'clock the next day. It needs to be taken at the same time every day. One of the medications that we give is a combination of carbidopa and levodopa. They're given in combination because the carbidopa will help prevent the breakdown of levodopa, so now it can actually enter the brain and do its job. But it may take several weeks before any changes are noted after the initiation of these medications. So carbidopa levodopa is considered to be a dopaminergic, and it will help restore dopaminergic activity with Parkinson's disease. So once again, it's given in combination of the other uh, with the others, and it has to be given at the same time every day. Adverse effects: it can turn some body fluids a darker color that will actually stain clothing. These clients will also require physical therapy, occupational therapy, education to the client and the family, and nutritional counseling. Surgically, there we can do what's called a stereotaxic pallidotomy, deep brain stimulation, gene therapy, glial cell-derived neurotrophic factor can be administered. Um, Again, nothing's really going to cure this, but we can help improve the symptoms. Which nursing interventions can help prevent a fall in a client with Parkinson's disease? Select all that apply. We're going to keep the client's call light within reach. That one makes sense. Avoid the use of throw rugs because these are a tripping hazard. Maintain the client's bed in a low position and provide a cane or a walker for ambulation. And brain tumors. Brain tumors are classified according to whether they are benign or malignant, the type of cells involved, and the site of the tumor. These tumors can result in death whether they're benign or malignant because they increase the intracranial pressure. Excuse me, and they put pressure on a particular area of the brain. The cause is unknown, but it may be caused by viral infection, exposure to radiation, head trauma, and immunosuppression. These clients experience a headache. The headache is going to be most common in the morning, that becomes increasingly severe and occurs more frequently as that tumor grows. Vomiting can occur without nausea or warning. We may see the papilledema, that would be the swelling around the eyes, seizures, difficulties with the speech, paralysis, and double vision. We diagnose this with a CT scan, an MRI, a brain scan, or cerebral angiography. We can treat this with surgery, radiation therapy, and/or chemotherapy. We can also do intraarterial or intrathecal administration with corticosteroids. You can give osmotic diuretics, analgesics, anticonvulsants, and antibiotics. Surgical procedures may require a craniotomy, a craniectomy, radioisotope administration, or gamma knife radiosurgery. So it's very important for us to support and treat those adverse effects of chemotherapy and radiation. And our teaching plan should include medication regimen, follow-up appointments, nutritional support, home care, rehabilitation, and referrals.